a senior Lisa is a senior public policy major, minoring in education. Lisa is a member of our university honors program since freshman year of fall 2020, is planning to attend graduate school in fall 2023 to receive a master's degree in public health or a doctor of public health degree. And I'm very excited for us to hear about the research that Lisa has been conducting. So Lisa, please go ahead.
Okay, sorry, it took me a while to find the unmute button, but good afternoon. Thank you guys for being here today. My name is Lisa Farraj, and today I will be presenting my university honors capstone entitled Arab Americans and the Invisible Health Crisis. I am a granddaughter of Jordanian and Palestinian immigrants. The hardship my grandparents faced along with the challenges they endured have shaped me into the person that I am. So I want to thank them for inspiring my capstone. I also want to thank my faculty mentor, Dr. Cecilia Aoun, for her support and mentorship throughout the process. All right, so we are going to begin by first explaining our research population. So who are Arabs? There are 22 countries in the Arab world, which is shown in the map. The Arab world is divided into 3 areas: the Maghrib, the Levant, and the Gulf states. 270 million Arabs reside in these countries who share the same national language, Arabic, culture, and common traditions. Now let's get more specific. Arab Americans are one of the multiple ethnic groups who contribute to America's melting pot. There are 3.7 Arab Americans who live in the United States. More than 2/3 of them live in just 10 states: California, Michigan, New York, Florida, Texas, New Jersey, Illinois, Ohio, Pennsylvania, and Virginia. Metropolitan LA, Detroit, and New York are home to 1/3 of the whole Arab American population. Detroit has the largest population in the nation. Upon immigration to the United States, Arabs are forced to actually identify as white by the American government. This white designation on the US Census makes it impossible to identify individuals of the Arab American population, thus making them an invisible minority. When Arab Americans are forced to mark white, this decreases the resources for Arab Americans and makes them unidentifiable when examining health outcomes. Since the US Census identifies anyone who comes from a country that has Arabic as the national language as white, there is not enough data to analyze for this minority group who remains invisible. Finally, a common American misconception is that all Arabs are Muslim, when in fact 70% of Arab Americans are Christians of different denominations. The other 30% of Arab Americans are Muslim. Arab ethnicity is not synonymous with Muslim. So keeping that in mind, let's delve into our framework. So for the scope of this presentation, the overall health of Arab Americans will be examined using the social determinants of health (SDH) model and also under the lens of cultural framework. The social determinants of health model is defined by the WHO, the World Health Organization, as the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. Ultimately, the social determinants of health is a framework which is used to understand the health and well-being of populations. They focus on 6 categories: economic stability, neighborhood and physical environment, education, food, community safety and social context, and finally, the healthcare system. With the SDH model, we will identify the sectors that contribute to the Arab American health crisis and evaluate what policies and practices can be implemented to better assess the needs of the Arab American population. In examining economic stability, Sarsour and Associates in 2010 assessed the health status, needs, behaviors, and access to services of Arab Americans. They found that 50% of Arab Americans reported household incomes below poverty level, 30% of them reported having no insurance, 43% of them reported problems in getting healthcare, including ability to pay, language barriers, and immigration. And they also found that first-generation Arab American immigrants are more educated, but more likely to live below poverty level and or be unemployed. Besides the poverty level, Arab Americans have risk factors such as asthma prevalence due to the location of residency, or from the SDH model, neighborhood and physical environment. This is due to poor housing quality, high levels of population, barriers to quality healthcare, and other risk factors found in urban immigrant reception areas, such as Detroit, Michigan, where Arab Americans reside. While education is a vital element in Arab American culture, those who immigrate here often have a lack of health literacy. In fact, according to Saeed and Associates in 2020, there was a direct link from the level of education on understanding colorectal cancer, or CRC. The national average is 57.3% compared to 22% of Arab Americans who are aware of CRC screenings. Arab Americans had 36% greater proportions of liver cancer, 44% greater thyroid cancer, 29% greater leukemia, and other diseases compared to non-Arab whites. Now on to food. So Arab Americans suffer from multiple health concerns. However, a popular one among this population is diabetes. As aforementioned, 1/3 of the Arab American population typically reside in metropolitan areas. According to Bertrand and Associates 2015, Detroit is where 80% of Arab Americans live, and 18% of metropolitan Arab American adults are actually affected by diabetes. The authors explain how despite Arab Americans suffering from this disease, they receive suboptimal care and achieve fewer treatment goals compared to the national average, which they suspect is due to the frequent health disparities within the immigration health group. Since Arab Americans are often overlooked on censuses and other population indicators, they are an underrepresented and invisible minority. With this being said, the true statistics of Arab Americans who are prone to and suffer from diabetes could be much higher. One female in a study conducted by Bertrand and Associates in 2015 shared how prominent carbs are within their diet. She shares how in the United States, they eat like they would in their home country. So they have legumes, lentils, and chickpeas, and they eat them very frequently. They do not participate in the consumption of canned goods or restaurant dining. Unfortunately, since carbs are so prominent in the diet of Arab Americans, it puts them at a higher risk for obesity and diabetes. Since Arab American culture is high and very prominent with food being at the focal point, their hospital nature and even their identity, it causes many health issues within a cultural framework perspective. So, like I said, food is an essential part of Arab American culture, especially for women. And so one woman, according to Shahib Hamad 2018, shared that she was serving her friends Arab American dishes, that the bread sat skyscraper high on plates on either end. So we see how prevalent carbs are within the diet. According to Feynman 2015, during type 2 diabetes, caloric increases have been due almost entirely to increased carbohydrates. Portion control is another issue that Arab Americans face because they constantly want to feel full because of the hospitality. So they constantly want to feed their guests food and make sure that they feel welcome. One quote from Bertrand and Associates is, "Come on, kids, eat. I used to make my kids big plates until they became fat." And so thus it becomes clear how the food aspect of the SDH model also has an intersectional relationship to the cultural framework which is used to study immigrant health. The lack of understanding of the religious dichotomy, meaning there are both Muslim and Christian Arabs, causes Americans to classify all Arab Americans as being Muslim. After September 11, 2001, Arab Americans became the target for discrimination and increased surveillance by the government. According to Padilla and Hasir in 2009, the researchers contend that the events of 9/11 negatively impacted Arab Americans constantly facing discrimination and abuse. According to their findings, 25% of respondents reported post-9/11 personal family abuse, and 15% reported that they personally had a bad experience related to their ethnicity. These stats correlate with the depression, anxiety, psychological distress, and other mental health factors caused by the lack of respect that Arab Americans feel from U.S. society. Another study found a positive correlation between racist events and poor mental health. Because Arab Americans must identify as white on the U.S. Census, they are placed in between two different cultures and perceptions. Moreover, when they visit their ancestral homeland, they are seen as too white, versus in America, they are too foreign. Another study in 2012 found a positive association between psychological distress and racial ethnic discrimination, which further supports the claim that The overall health of Arab Americans, especially mental health, is affected through discrimination and stress. Stress also originates from Arabs who have little to no health literacy and English proficiency. Consequently, Arab Americans, whether born or naturalized in the US, continue to be at a disadvantage in healthcare system, which systematically discriminates against them, thus affecting their overall health. Arab Americans suffer from language barriers within the healthcare system and cultural differences. These cultural differences include patriarchal beliefs in which the healthcare provider can only communicate with the head of the household male. This communication is still lacking as some of the males have limited English proficiency. According to Shamsi and Al-Matri 2020, they share that language barriers are responsible for reducing the satisfaction of medical providers and patients, as well as the quality of healthcare delivery and patient safety. If Arab Americans, especially those lacking proficiency in the English language, are unable to understand healthcare professionals, then they are automatically disadvantaged and their overall health is affected. According to Bertrand and Associates 2015, this health disparity is attributed to cultural norms and health behaviors, like we saw with food. Thus, the language barrier and lack of access to interpreters for Arab Americans affect their overall health and access to healthcare. Arab Americans are unable to express to their healthcare professionals what their needs are from a health perspective and what struggles they are facing. Similarly, Arab Americans are unable to understand any advice given to them, even if they can translate their needs. A study in 2020 showed that Arab-speaking immigrants self-rated their health lower than Arab immigrants who were either born in the US or were English-speaking immigrants. Their study thus suggested the language barrier as a contributing factor to healthcare access or lack thereof, healthcare quality, or their overall health status. Regarding language as a factor to healthcare, the authors looked at language barrier, interpreter need, and health literacy level. The same study in 2020 concluded that there is a positive correlation between health literacy and education level. They state that the perception of the language as a barrier to healthcare was found to associate positively with the level of education of the participant, such as those with college education, and higher have no issues with comfortably communicating in English. Despite only 16% of participants perceived having a language barrier, this was typically a result of education and not too reliant on the presence or availability of the interpreter or translation services. In order for Arab Americans to be accurately represented and accommodated within the healthcare system, the first policy that must be instilled is in regard to the US Census. When indicating race, individuals are asked to choose which race they identify. Since Arab Americans are not properly accounted for, there cannot be research conducted with this population to evaluate specific health concerns and potential solutions. This national policy recommendation calls for the US Census to include SWANA or MENA as a 10th category available for Arab Americans to select on the census. They should also include countries of origin which fall under this country. This will assist Arab Americans in identifying the proper box to mark so that their voices may be accounted for. In a policy brief from the regional office of the WHO, proponents stated that health literacy, responsiveness of health services, and resources can be improved through creation of culturally competent workforce and provision of readily accessible information. For example, in multiple languages and through outreach initiatives. For Arab Americans, it is important to have healthcare professionals who can accommodate their lack of English proficiency and cultural components. As mentioned in a study by 2020, language barriers affected the satisfaction of providers and patients. Thus, eliminating this barrier will allow Arabs to have better access to quality healthcare, which will increase their overall health. By being culturally competent, healthcare providers will be better equipped to communicate with Arab Americans and will be more understanding of any cultural differences which may cause miscommunication of information. For Arab Americans, having culturally competent healthcare workers who can not only communicate and explain health outcomes, such as diabetes, but also respect and understand their culture could ultimately assist with closing the gaps in healthcare as demonstrated in the SDH framework. And then finally, we have practice recommendations. Through the findings of Saeed and Associates, it became clear the lack of health literacy among Arab Americans. For example, the researchers found that only 7% of Arab Americans knew what a sigmoidoscopy was compared to the US national average of 84.3%. Within communities, schools can host informational workshops that focus on a variety of common illnesses and diseases. These workshops can also be in partnership with local hospitals, where medical professionals can come to the host school and they can start educating the participants. Another practice recommendation for Arab Americans is to have a mobile or to have multiple mobile health clinics travel in metropolitan areas where they are heavily populated, such as Detroit, LA, and New York. Mobile clinics are yet another access point to receive healthcare in conjunction with gain health literacy from the community-based school events. Due to the simple fact that mobile clinics are satellite facilities to access healthcare, a larger demographic is able to be served. Mobile clinics are yet another way for patients to access services such as primary care and screening, preventative specialty care, and social interventions. Through the option of mobile clinics, the barrier of transportation is removed as demonstrated by the SDH model. And so I just want to encourage you that if you were interested at all, my official capstone will be posted on the University Honors website. And so here is that link. And other than that, thank you guys so much for listening and for attending.
Thank you so much, Lisa. Great presentation. I'll remind you to stop recording.